Today's session is about diuretics. So before we go into the topic, we will see what are the learning objectives of today's session. At the end of these sessions, the students should understand how urine is produced, how urine is concentrated, what are diuretics, how are they classified, the different groups of diuretics, the mechanism of action, uses, adverse effects and contraindications of various groups of diuretics. So we'll see how urine is produced first. The kidneys are the waste treatment plants of our body. Kidneys have abundant blood supply and they will filter the blood which is passing through the kidney, and it will result in the excretion of urea, water and also toxins and some amount of electrolytes as well. So it filters the body of urea, water, toxins and electrolytes. And since kidneys control the excretion of water from our body, it determines how much water is present in our body. When the water level in our body is less, it will conserve water by reducing the excretion, and when the water level in our body is high, it will excrete more amount of water. The functional unit of kidney is called as nephron. So these are the basic filtering units of kidneys, and the nephrons are arranged in such a way that some parts of the nephron are in the cortex, whereas some parts are located in the medulla. So as you can see, this is a nephron, this is the Bowman's capsule, this is the proximal convoluted tubule, this is the descending limb of loop of Henle, ascending limb of loop of Henle, then distal convoluted tubule and the collecting tubule. So some parts of the nephron, they are arranged in the medulla and some parts are present in the cortex, and this mechanism and this anatomical position of the nephron is for the concentration of urine. So if you see the glomerulus, the proximal convoluted tubule and the distal convoluted tubule, they are located in the cortex, whereas the loop of Henle and the collecting tubule, they are located in the medulla. The functional unit of the kidney is the nephron, and the most important filtering aspect of the nephron is a glomerulus. The glomerulus is a tuft of capillaries which is surrounded by areas of nephron. Okay, and this area that surrounds this tuft of capillaries, they are known as Bowman's capsule. And this glomerulus has got cells with gaps in between them, through which blood and waste materials can be filtered into the Bowman's capsule, okay. And the product that is filtered into the Bowman's capsule, it is known as ultrafiltrate. Okay. So about 100 ml ultrafiltrate is produced per minute, but the amount of urine produced is 1 ml. So almost 99% of the ultrafiltrate is reabsorbed. This reabsorption of components from the ultrafiltrate is energy consuming. So that is why kidneys consume around 7% of the total body energy expenditure. So for this concentrating process, concentration of this ultrafiltrate, we require a large amount of energy. That is why kidneys consume around 7% of the total body energy expenditure. So what are diuretics? Diuretics are agents that increase the urine production. So the diuretics, they are basically classified into 5 groups. They are carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, potassium sparing diuretics, and osmotic diuretics. So these are the 5 groups of diuretics. Diuretics are agents that increase urine production. They are classified into carbonic anhydrase inhibitors, loop diuretics, thiazide diuretics, potassium sparing diuretics, and osmotic diuretics. So now we will see what are the concentrating mechanisms of ultrafiltrate in various areas of the nephron. First we will see what happens in the proximal convoluted tubule. So the fluid that is filtered from these glomerulus will reach the Bowman's capsule. This is known as ultrafiltrate, and this ultrafiltrate will move from the Bowman's capsule into the proximal convoluted tubule, and this proximal convoluted tubule, it is present in the cortex. The proximal convoluted tubule is freely permeable to water. So some amount of water reabsorption takes place in the proximal convoluted tubule. And proximal convoluted tubule also reabsorbs sodium and potassium. And 65% of the sodium and potassium reabsorption takes place in the proximal convoluted tubule. In the proximal convoluted tubule, there is also absorption of bicarbonate ions. And 85% of the bicarbonate reabsorption takes place in the proximal convoluted tubule. Proximal convoluted tubule also reabsorbs amino acids and 100% of the amino acid reabsorption takes place in the proximal convoluted tubule. It also reabsorbs glucose, and 100% of the glucose reabsorption also takes place in the proximal convoluted tubule. The proximal convoluted tubular cells contain sodium hydrogen exchanger, and with this exchanger, sodium is reabsorbed from the ultrafiltrate into the proximal convoluted tubular cell in exchange for H plus ions. So sodium will be reabsorbed from the ultrafiltrate, whereas hydrogen ions will be secreted into the ultrafiltrate. And the secreted H plus ions will combine with bicarbonate ions which are present in the ultrafiltrate, and this will form carbonic acid. And the formed carbonic acid will be degraded by an enzyme called as carbonic anhydrase, and this will help in the dissociation of carbonic acid into water and carbon dioxide. And since carbon dioxide is a gas, it will freely diffuse into the proximal convoluted tubular cells. So the secreted H plus ions combined with bicarbonate ions to form carbonic acid, which will be broken down by carbonic anhydrase enzyme into water and carbon dioxide. And this carbon dioxide will diffuse into these cells where it combines with water to form carbonic acid in the presence of the same enzyme, carbonic anhydrase. And this carbonic acid will dissociate into H plus and HCO3 minus ions. So this H plus ions will be used for this sodium hydrogen exchanger for reabsorption of sodium. The bicarbonate ions will be reabsorbed along with sodium ions. So in effect, due to this process, there is reabsorption of sodium and bicarbonate. The first group of diuretics, they are carbonic anhydrase inhibitors. So what they do is they will inhibit this carbonic anhydrase enzymes which are present in the proximal convoluted tubular cells. So this carbonic anhydrase enzyme is inhibited. So as a result of this, there is no dissociation of carbonic acid to water and carbon dioxide. And also the combination of water and carbon dioxide to form carbonic acid will not take place in the proximal convoluted tubular cells. So that will result in reduced H plus ions. And this H plus ions, they are essential for the sodium hydrogen exchanger. So since this H plus ion is reduced, the amount of sodium reabsorbed is reduced. And since carbonic anhydrase enzyme is not working, there is no formation of HCO3 minus ions. So that will result in reduced reabsorption of sodium and bicarbonate ions. The proximal convoluted tubular cells reabsorb sodium, potassium, bicarbonate ions, glucose and amino acids. And the luminal surface of the proximal convoluted tubular cells contains sodium hydrogen exchanger, which will reabsorb sodium in exchange for H plus ions, which will combine with the bicarbonate ions which are present in the ultrafiltrate to form carbonic acid. And this carbonic acid will be dissociated by an enzyme called as carbonic anhydrase, which will dissociate it into water and carbon dioxide. And since carbon dioxide is a gas, it will diffuse into the cell where it will be combined with water to form carbonic acid, again catalyzed by carbonic anhydrase enzyme. The carbonic acid will dissociate into H plus ions and HCO3 minus ions. This H plus ions will be used by the sodium hydrogen exchanger for reabsorbing sodium, and the bicarbonate ion formed will be reabsorbed along with the sodium. So carbonic anhydrase inhibitors, they will inhibit this enzyme carbonic anhydrase, thereby reducing the formation of H plus ions in the proximal convoluted tubular cells. This will result in reduced reabsorption of sodium ions, reduced reabsorption of bicarbonate ions. Now we will see what happens in the loop of Henle. The descending limb of loop of Henle is permeable to water. So since this area is the medulla and this area is the cortex, you should know that medulla is hypertonic whereas the cortex is hypotonic. So when this ultrafiltrate flows through the descending limb of loop of Henle, and since the descending limb is permeable to water, water will be reabsorbed into the cortex and also into the medulla. So this will result in concentration of the ultrafiltrate. Ultrafiltrate will get concentrated as the ultrafiltrate moves through the loop of Henle towards the medulla. And the ascending limb of loop of Henle is impermeable to water. The ascending limb of loop of Henle is permeable to solutes. And the thin ascending limb of loop of Henle is permeable to urea. So since the medulla is hypertonic and since this area is permeable to solutes, as the ultrafiltrate goes up the loop of Henle, urea will be secreted into the ultrafiltrate. And as the ultrafiltrate goes up the thick ascending limb of loop of Henle, this area is permeable to solutes and there is reabsorption of sodium taking place in the thick ascending limb of loop of Henle. So we will see what happens in the thick ascending limb of loop of Henle. The thick ascending limb of loop of Henle contains transporters in the luminal surface which will transport sodium into the cell along with potassium and also chloride ions. So these transporters, they are called as sodium potassium 2 chloride symport. Symporter means any transporter that transports ions in one direction. So all these ions, they are transported into the proximal convoluted tubular cells. So this transporter is known as sodium potassium 2 chloride symport. So the absorbed sodium is exchanged for potassium ions. So sodium is reabsorbed and potassium is secreted into the cells of thick ascending limb of loop of Henle. And the potassium ions, they are reabsorbed along with each other into the interstitium where this will be reabsorbed. So if you see, there is an extra potassium ion here. Okay. And these cells, they contain free potassium channels in the luminal surface. So this potassium ion will be secreted into the ultrafiltrate. So the amount of potassium in the ultrafiltrate increases. So when the amount of potassium ions increases, the positive charge increases in the ultrafiltrate. So when there is presence of positive charge in the ultrafiltrate, it will repel other positively charged ions like calcium and magnesium. So this process will result in the reabsorption of calcium and magnesium as well. So in the thick ascending limb of loop of Henle, there is reabsorption of sodium, chloride, potassium, magnesium and calcium. So what happens when we are giving diuretics that will act on the thick ascending limb of loop of Henle? So these diuretics, they will inhibit this sodium potassium 2 chloride symport. So there is no reabsorption of sodium, chloride or potassium. So since potassium is not here, there is no excess potassium here. So there is no secretion of potassium here. So the positive charge also reduces. So this will result in reduced reabsorption of calcium and magnesium. So the loop diuretics, they will inhibit the sodium potassium 2 chloride symport which is present in the luminal surface. When that is inhibited, the reabsorption of sodium, potassium and chloride is inhibited. So when this is inhibited, the amount of intracellular potassium reduces and that will result in reduced secretion of potassium into the ultrafiltrate. And since there is lesser positive charge in the ultrafiltrate, there is minimal repulsion of calcium and magnesium, and this will result in reduced reabsorption of calcium and magnesium. Now we will see what happens in the distal convoluted tubule. Distal convoluted tubule is impermeable to water. So we will see what happens in the distal convoluted tubule. The distal convoluted tubule contains transporters which will transport sodium and chloride in the same direction into the distal convoluted tubular cells. So these transporters, they are called as sodium chloride symport because these transporters transport sodium and chloride in the same direction. So the reabsorbed sodium is exchanged for potassium ions. The luminal surface of the distal convoluted tubular cells, they also contain calcium channels, and these calcium channels will reabsorb the calcium and the absorbed calcium will be exchanged for sodium ions. Okay. So this is a site where parathormone act. Parathormone is a hormone secreted by the parathyroid gland and it increases the reabsorption of calcium from the distal convoluted tubular cells. So when parathormone is released, it will act on the distal convoluted tubular cells and it will increase the number of calcium channels which are present in the distal convoluted tubular cells. So that will result in increased reabsorption of calcium. So we will see how drugs work on the distal convoluted tubular cells. There are a group of diuretics that work on the distal convoluted tubular cells. They are known as thiazide diuretics. And the thiazide diuretics, they will inhibit this sodium chloride symport. So there is less reabsorption of sodium and chloride. So this will result in reduced levels of intracellular sodium. So when intracellular sodium is reduced, more amount of calcium will be exchanged for increasing the concentration of sodium. So this will result in reduced levels of intracellular calcium. So when the calcium in the intracellular is reduced, this will result in increased reabsorption of calcium. Thiazide diuretics, by blocking this sodium chloride symport, it will reduce the intracellular concentration of sodium. So when the intracellular concentration of sodium is reduced, more amount of sodium will be pumped into the, and this will result in reduced reabsorption of sodium and chloride. And when the sodium chloride reabsorption is reduced, intracellular levels of sodium will reduce. That will result in pumping of sodium into the cells in exchange for calcium. So the calcium will be pumped into the interstitium in exchange for sodium, and this will result in reduction in levels of intracellular calcium, and that will result in activation of these channels, and that will result in reabsorption of calcium. So thiazide diuretics will reduce the reabsorption of sodium and chloride, and it will increase the reabsorption of calcium. Now we will see what happens in the collecting tubule. Collecting tubule is the last part of the nephron where urine is concentrated. So there is reabsorption of water and electrolytes in the collecting tubule. Almost around 2 to 5% of the salt reabsorption takes place in the collecting tubule. Collecting tubule also determines how concentrated the urine is. It is an area which determines the amount of sodium and potassium in the urine. So it is an area where potassium is secreted into the urine. So collecting tubule determines the amount of potassium in our body. And the collecting tubule is a site where mineralocorticoids act and also ADH acts. Okay. So we will see what happens in the collecting tubule. The collecting tubule has sodium channels present in the luminal surface. These are known as epithelial sodium channels or ENaC. So these channels will transport sodium into the cells, which is exchanged into the interstitium for potassium ions. For each sodium ion absorbed into the interstitium, one potassium ion is secreted into the cells. So the potassium ions secreted will move into the ultrafiltrate through free potassium channels. And in the collecting tubule, there is reabsorption of chloride ions, and these chloride ions will be reabsorbed through the spaces in between the cells of the collecting tubule. Okay. And this is a site where mineralocorticoids act. Especially aldosterone. Aldosterone will increase the number of epithelial sodium channels, and also it will increase the activity of epithelial sodium channels. So this will result in increased reabsorption of sodium. So when more sodium is reabsorbed, more potassium will be secreted into the ultrafiltrate, that will result in loss of potassium. So in the collecting tubule, essentially one sodium ion is reabsorbed from the ultrafiltrate in exchange for one potassium ion secreted into the ultrafiltrate. Collecting tubule is also a site of action for vasopressin, and this vasopressin will increase the water reabsorption from the collecting tubule. So we will see the different groups of diuretics, and we will see each individual group of diuretic. So there are diuretics that act on the proximal convoluted tubule, there are diuretics that act on the thick ascending limb of loop of Henle, there are diuretics that act on the distal convoluted tubule, and there are diuretics that act on the collecting tubule. So we will see the agents that act on the proximal convoluted tubule first. If you remember, carbonic anhydrase inhibitors are the agents that act on the proximal convoluted tubule. So the carbonic anhydrase inhibitors are acetazolamide, dichlorphenamide, and methazolamide. So these agents, they act on the proximal convoluted tubule. So if you remember, there is an enzyme carbonic anhydrase which will help in the dissociation of carbonic acid to carbon dioxide and water, which will result in the movement of carbon dioxide into the cell, where it combines with water in the presence of carbonic anhydrase to form carbonic acid. Okay. So this carbonic anhydrase enzyme is inhibited by these carbonic anhydrase inhibitors. So as a result, there is reduced reabsorption of sodium and also bicarbonate ions. So when you are administering carbonic anhydrase inhibitors, it will increase the urinary excretion of bicarbonate ions by 35%. Carbonic anhydrase inhibitors also increase the urinary excretion of sodium by 5%. Even though it reduces the sodium reabsorption in the proximal convoluted tubule, there are many areas from which sodium can be reabsorbed. So the increased amount of sodium in the ultrafiltrate will result in increased reabsorption of sodium in the thick ascending limb, of loop of Henle, distal convoluted tubule and collecting tubule. So carbonic anhydrase inhibitors will inhibit the reabsorption of sodium. So this will result in increased levels of sodium in the ultrafiltrate. And more amount of sodium present in the ultrafiltrate will trigger the reabsorption of sodium from the thick ascending limb, from the distal convoluted tubule and also from the collecting tubule. So the amount of sodium that is secreted, that is the amount of sodium increased in the ultrafiltrate will be reabsorbed at various areas of the nephron. This will result in only a mild increase in sodium secretion in the urine. But if you remember, in the collecting tubule, sodium is reabsorbed in exchange for potassium, right? So when this high amount of sodium is reaching the collecting tubule, more amount of potassium will be secreted into the ultrafiltrate, which will result in increased excretion of potassium, and that will result in a 70% increased excretion of potassium. Okay, so these are the changes that happens in the urine if you are giving carbonic anhydrase inhibitors. It will increase the excretion of bicarbonate ions by 35%. It only produces a mild increase in sodium excretion, and it produces a significant increase in potassium ions, that is a 70% increase in potassium. Carbonic anhydrase inhibitors, they are also used for the treatment of glaucoma, because carbonic anhydrase enzyme is essential for the secretion of bicarbonate ions into the aqueous humor. So when bicarbonate ions, they are secreted into the aqueous humor, water will also be secreted into the aqueous humor. So when carbonic anhydrase inhibitors are given, this bicarbonate secretion is reduced, thereby reducing the secretion of water into the aqueous humor. This will result in reduced intraocular pressure. So hence it is used in glaucoma. Carbonic anhydrase inhibitors increase the urinary excretion of bicarbonate ions. So when more amount of bicarbonate ions are excreted through the urine, it will result in metabolic acidosis. Acetazolamide has got 100% bioavailability. They are excreted through kidneys. So dose should be reduced in renal failure. Carbonic anhydrase inhibitors are used for the treatment of edema, and they are used in combination with other diuretics. They are also used for the treatment of glaucoma. And topical agents are used for the treatment of glaucoma, especially dorzolamide and brinzolamide. These are the topical carbonic anhydrase inhibitors used for the treatment of glaucoma. Carbonic anhydrase inhibitors, they are also used for the prophylaxis of mountain sickness. In mountain sickness, there is development of cerebral edema and pulmonary edema as a result of hypoxia. So when you are giving this carbonic anhydrase inhibitors, it will result in excretion of bicarbonate ions. That will result in development of acidosis. Acidosis will stimulate the respiratory center, and this will result in the person hyperventilating, thereby reducing cerebral edema and also pulmonary edema. Now we will see what are the adverse effects of carbonic anhydrase inhibitors. The major adverse drug reaction is bone marrow suppression. Can also produce skin rashes and also metabolic acidosis. Carbonic anhydrase inhibitors, they are used for the treatment of edema, they are used for the treatment of glaucoma and also for the prophylaxis of mountain sickness. Now we will see the agents that act on the thick ascending limb of loop of Henle. These agents, they are acting on the loop of Henle, hence they are called as loop diuretics. So three loop diuretics are available for use. They are furosemide, torsemide and bumetanide. So these agents, they act on the thick ascending limb of loop of Henle. So there is a transporter that is present in the thick ascending limb of loop of Henle. It is called as sodium potassium 2 chloride symbiote. And the sodium potassium 2 chloride symbiote will reabsorb sodium, potassium and chloride. So by inhibiting that, it will increase the urinary excretion of sodium, it will increase the urinary excretion of potassium, it will increase the urinary excretion of chloride, it will increase the urinary excretion of magnesium and also calcium. So thiazide diuretics are a group of diuretics that will increase excretion of all cations. So it increases the excretion of sodium, potassium, chloride, calcium and magnesium. Loop diuretics, they also produce vasodilation by producing prostaglandin I2 or PGI2. So this PGI2 will dilate the blood vessels and can produce vasodilation. All the loop diuretics can be given as oral formulation. Intravenous formulations are available for all except torsemide. Loop diuretics are eliminated by the kidneys, hence dose should be reduced in patients with renal failure. Torsemide is more potent than furosemide and bumetanide is even more potent. So the most potent loop diuretic is bumetanide. So we will see what are the uses of loop diuretics. The most important use of loop diuretic is for the treatment of acute pulmonary edema. This is a very important question. This has been asked as a short note question. This has been asked as a pharmacological basis question. And this also has been asked for as MCQ question. So acute pulmonary edema is a condition where there is fluid accumulation in the lungs. Okay. So when you are giving loop diuretics, this loop diuretics will produce vasodilation. That will result in shift of fluid from pulmonary circulation to systemic circulation. And also use of loop diuretics will produce diuresis, and this will reduce the plasma volume as well. So when there is vasodilation and when there is reduction in plasma volume, this will result in reduced formation of edema in the lungs. So it can be used very effectively for the treatment of pulmonary edema. So this loop diuretics, they act in pulmonary edema by two mechanisms. One is by producing vasodilation. So by producing vasodilation, it will shift the blood from the pulmonary circulation into the systemic circulation. So that will result in reduced pressure in the pulmonary blood vessels and reduced exudation of fluid. Second thing is it produces diuresis, and by diuresis it will reduce the fluid volume in our body, and that will also reduce the formation of pulmonary edema. Loop diuretics are also used for the treatment of cardiac failure. In cardiac failure, the heart is not able to pump blood according to the requirements of the body. So that will result in accumulation of fluid in various parts of the body, especially in the lungs, which can result in pulmonary edema. So if you are giving loop diuretics, it can provide symptomatic relief in patients with cardiac failure. Loop diuretics, they are also used for the treatment of edema. All types of edema such as renal edema, hepatic edema, and also cardiac edema. And this is the agent of choice for edema due to renal failure. So when you are giving loop diuretics will stimulate the release of PGI2 or prostaglandin I2, and this will produce vasodilation, especially of the renal blood vessels. So when the renal blood vessels dilate, the more amount of blood will be circulating into the kidney, and this will result in increased renal perfusion. So this has got protective effect in patients with renal failure. It's also used for edema due to cardiac causes. Loop diuretics, they are also used for treatment of edema due to hepatic causes. And hepatic damage can reduce the albumin levels, and that can result in formation of edema. Loop diuretics, they are also used for the excretion of poisons and toxins. So if these toxins, they are excreted by the kidneys and they are excreted through the urine, by increasing the urine output, you can increase the excretion of these toxins. So this is known as forced diuresis, and this is used in poisoning. Loop diuretics increase the excretion of calcium. So it can be used for the treatment of hypercalcemia. So in patients who are having hypercalcemia, their serum calcium levels will be high, and this loop diuretics will excrete the excess amount of calcium that will reduce the calcium to normalcy. Loop diuretics increase the excretion of all the cations. By increasing the excretion of sodium ions, it can produce hyponatremia. By increasing the excretion of calcium, can produce hypocalcemia. By increasing the excretion of magnesium, it can produce hypomagnesemia. By increasing the excretion of potassium, it can produce hypokalemia. Potassium is very essential for the secretion of insulin. By increasing the excretion of potassium, it reduces the serum levels of potassium, reducing insulin secretion. So this can result in hyperglycemia. Loop diuretics reduce the levels of HDL cholesterol and it can increase the levels of LDL cholesterol. So these are the adverse drug reactions associated with loop diuretics. So loop diuretics, they act on the thick ascending limb of loop of Henle. There it reduces the reabsorption of sodium, potassium, chloride, calcium and magnesium. So the most important indication of loop diuretics is for the treatment of acute pulmonary edema, where it relieves the edema by producing vasodilation, which is by release of prostaglandin I2, and also by producing diuresis. It is also used for edema due to various causes, cardiac edema, renal edema and also hepatic edema. And it is the agent of choice for renal edema because it produces vasodilation and improves the renal perfusion. So now we will see what are the diuretics that act on the distal convoluted tubule. So these diuretics, they are called as thiazide diuretics. These include chlorthalidone, hydrochlorothiazide and indapamide. And these agents, they act on the distal convoluted tubule. They increase the urinary excretion of sodium and potassium. So if you remember, thiazides increase the reabsorption of calcium from the distal convoluted tubule. So it is a diuretic that can increase the serum calcium levels. Thiazide diuretics, they are given orally. The newer agents, especially chlorthalidone, it is very long acting. So it can be given once daily. The major use of thiazide diuretic is for the treatment of hypertension. And chlorthalidone is the preferred agent because of its long duration of action and once daily dosing. Thiazide diuretics, they are also used for the treatment of edema. Thiazide diuretics, they are used for the treatment of renal calculi. This renal calculi, they are due to deposition of calcium stones inside the kidneys. Okay. So thiazide diuretics, they will reabsorb the calcium from the distal convoluted tubule and that will result in reduced calcium in urine and that will reduce the renal calculi. Thiazide diuretics also reabsorbs the calcium from the distal convoluted tubule and increases the concentration of plasma calcium. So it is used for the treatment of osteoporosis. Osteoporosis is a condition which is seen in elderly. There is reduced bone mineralization and this thiazide diuretics, by increasing the calcium reabsorption from the distal convoluted tubule, it will improve the bone mineralization in osteoporosis. So we will see what are the adverse effects of thiazide diuretics. Thiazide diuretics increase the urinary excretion of sodium that can result in hyponatremia. Thiazide diuretics increase the urinary absorption of calcium and this can result in hypercalcemia. Thiazide diuretics reduce the reabsorption of magnesium. This can result in hypomagnesemia. It also reduce the reabsorption of potassium, which can result in hypokalemia. And since potassium is very essential for insulin secretion, reduced potassium will result in reduced insulin secretion and that can result in hyperglycemia. Thiazide diuretics also reduce HDL levels and it increases LDL levels, similar to loop diuretics. The only difference between Thiazide diuretic and loop diuretic is the reabsorption of calcium. Thiazide diuretics increase the reabsorption of calcium, whereas loop diuretics will increase the excretion of calcium. Now we will see what are the diuretics which act on the collecting tubule. So these diuretics, they are called as potassium sparing diuretics. So if you remember, in the collecting tubule, sodium is reabsorbed in exchange for potassium. So any agent that blocks the sodium potassium exchange will result in reduced secretion of potassium, and this will result in retention of potassium in the body, and hence they are called as potassium sparing diuretics. So these agents, they act on the collecting tubule. So two groups of agents are available for use. One is known as the aldosterone antagonist, which antagonizes the hormone aldosterone, and these include spironolactone, candrenone and eplerenone. And the second group of agents, they inhibit the sodium channels which are present in the collecting tubule. And two agents are available for use, amiloride and triamterene. So these agents, they increase the urinary excretion of sodium and chloride, and this increase is only very mild. Among the potassium sparing diuretics, spironolactone, it has got affinity for the receptors of androgen and also progesterone. So this, when used in males, can produce gynecomastia. It can produce impotence, and it can also produce menstrual irregularities. And this adverse drug reaction is only present for spironolactone, not for the other aldosterone antagonists, and it is not present for the epithelial sodium channel inhibitors. All the potassium sparing diuretics, they are metabolized by the liver. Triamterene is excreted by the liver, and all the metabolites, they are excreted by the kidneys. Now we will see what are the uses of potassium sparing diuretics. Potassium sparing diuretics, they are combined with loop diuretics or thiazide diuretics. Because loop diuretics and thiazide diuretics, they will increase the excretion of potassium and can produce hypokalemia. These potassium sparing diuretics, they will reduce the excretion of potassium, thereby antagonizing this adverse effect of loop diuretics and thiazide diuretics. So it is used as a diuretic and also as an antihypertensive. And these potassium sparing diuretics, they are used for the treatment of resistant hypertension. And potassium sparing diuretics, especially aldosterone antagonists, they are used in cardiac failure. And the use of aldosterone antagonists will improve the survival in patients with cardiac failure. Now we will see what are the adverse effects of potassium sparing diuretics. By increasing the plasma concentration of potassium, these agents can produce hyperkalemia. And this hyperkalemia is very common if you are using potassium supplements. Or when you are combining these potassium sparing diuretics with AC inhibitors or ARBs. AC inhibitors and ARBs, they produce hyperkalemia on their own. So if you are combining potassium sparing diuretics along with AC inhibitors or ARBs, it can produce severe hyperkalemia. And spironolactone, it has got affinity for receptors of androgen and also progesterone, hence produces gynecomastia. impotence, and menstrual irregularities. Spironolactone can produce severe gastritis. Triamterene will antagonize folic acid, and this can result in megaloblastic anemia. Coming to the last group of diuretics, the osmotic diuretics. These include mannitol, urea, isosorbide, and glycerin. Isosorbide and glycerin, they are available as oral formulations. Mannitol and urea, they are available as parenteral formulations. These agents, they are freely filtered by the glomerulus. And they are excreted in urine. So when you are administering osmotic diuretics, these agents, they have got a very high osmolality. So when these agents are administered, these agents will increase the osmolality of the plasma. This will result in movement of fluid from the extravascular compartment into the vascular compartment. This will increase the extracellular fluid volume, because more amount of fluid is moving into the vascular compartment from the intracellular. So this will reduce the viscosity of blood. So when the viscosity of blood is reduced, this will increase the renal perfusion. And when the perfusion to the kidneys is increased, this will result in increased renal perfusion will reduce the release of renin, and it also reduce the tonicity in the medulla. Reduce medullary tonicity. So if you remember, the medulla is hypertonic, and this hypertonicity is very essential for reabsorption of water and also secretion and reabsorption of electrolytes. So when renal perfusion increases, this will reduce the medullary tonicity. So there will be reduced reabsorption of water and reduced reabsorption of solutes, and there is reduced secretion of urea. So the reduction in medullary tonicity will reduce reabsorption of water and electrolytes. This will result in urination. We will see what are the uses of these osmotic diuretics. Osmotic diuretics, they are used for the treatment of cerebral edema. So in cerebral edema, these osmotic diuretics, they will increase the osmolality of the plasma. These osmotic diuretics, they will increase the osmolality of plasma. So that will result in movement of fluid from the extravascular compartment into the blood vessels. So it will result in movement of fluid from the edematous area of the brain into the blood vessels, thereby resolving edema. They are also used for the treatment of glaucoma, especially angle closure glaucoma. So the two main indications for osmotic diuretics are cerebral edema and for the treatment of angle closure glaucoma. Osmotic diuretics should not be used in patients with pulmonary edema, because it will precipitate pulmonary edema. It should not be used in patients who are having cardiac failure. because it can precipitate pulmonary edema in these patients. And the osmotic diuretic, glycerin is converted to glucose in our body, and that can result in increased blood glucose. So it should not be used in diabetics. These osmotic diuretics, they are contraindicated in renal failure and also in intracranial hemorrhage. So to summarize, you should remember the mechanism of urine production. Urine is produced by the basic functional unit of the kidney known as nephron, and there are various areas where urine is concentrated. One is the proximal convoluted tubule, the next one is the loop of Henle, then the concentration takes place in the distal convoluted tubule and in the collecting tubule. So there are agents that act on the proximal convoluted tubule. These are carbonic anhydrase inhibitors, which are used for the treatment of glaucoma. They are used for the treatment of edema and also for the treatment of the second group of agents. They act at the loop of Henle, where it reduces the reabsorption of sodium, potassium, chloride, calcium, and magnesium. These agents, they are called as loop diuretics because they act at the loop of Henle. These agents, they are used for the treatment of edema, especially cardiac edema, renal edema, and also hepatic edema. And the third group of agents, they act at the distal convoluted tubule. These agents, they are called as thiazide diuretics. They are mainly used for the treatment of hypertension. And the fourth group of agents, they act at the collecting tubule, where it reduces the reabsorption of sodium and conserves potassium. These agents, they are called as potassium sparing diuretics because they conserve potassium. These agents, they are used in combination with loop diuretics for preventing hypokalemia. And the last group of agents, they are osmotic diuretics. They are mainly used for the treatment of cerebral edema and also for the treatment of acute congestive glaucoma. I hope this session was enjoyable for you. There are a lot of short note questions and multiple choice questions and also pharmacological basis questions from this session. So please remember the explanation for all of those. Thank you.